The broadcast is now starting. All attendees are in listen-only mode.
Welcome to this webinar on the latest on Ulipristal Acetate, the Swiss Army knife of hormonal treatment. I am Sarah Ramaya, Curriculum Designer at ASRM. Please join me in welcoming my colleagues Jessica Goldstein and today's moderator, Dr. Kurt Barnhart. Before we begin, please note, this webinar was developed by the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. Let me introduce our moderator, Dr. Barnhart, a tenured professor in both the Department of Obstetrics and Gynecology and a senior scholar in the Center for Clinical Epidemiology and Biostatistics at Penn School of Medicine. He currently serves as the Director of Women's Health Clinical Research Center and is the Vice Chair for Clinical Research at Penn School of Medicine. Dr. Barnhart received his medical degree at Mount Sinai School of Medicine and performed his residency and fellowship training as well as MSce degree at Penn School of Medicine. Dr. Barnhart has 22 years of continuous NIH-supported research and has been involved in more than 60 clinical trials, translational research, and outcome studies in women's health. Dr. Barnhart serves as the District 3 Secretary for the American College of Obstetrics and Gynecology, chairs the ASRM Scientific Program Committee, and is a member of the ASRM Research Task Force. Dr. Barnhart is the video and new media editor for Fertility and Sterility, an ASRM journal. I will now turn this presentation over to Dr. Barnhart to introduce our panelists.
Thank you very much. It's a privilege to work with ASRM on these wonderful webinars, and this is a good one. We're going to talk about ulipristal acetate and its many ways it's to be used in gynecologic disorders and as well as contraception. And I have a very illustrious panel, including Jeffrey Jensen, Thomas Kimball, and Michael Thomas. The first presenter that I get to introduce is Dr. Jensen. Dr. Jensen is a board-certified reproductive endocrinology and fertility at Oregon Health and Science University. He has served in the United States Naval Medical Corps. He has worked very closely with the Oregon National Primate Center with special interests in family planning. He's going to talk to us about ulipristal acetate for emergency contraception, and I look forward to his presentation. Thank you for joining us, Jeff.
All right, so I'm going to talk to you today about UPA for emergency contraception. Next slide. I have a few conflicts, but none that are in direct relationship to the program. Next slide. The important take-home message regarding emergency contraception with oral agents is that ulipristal acetate is more effective than levonorgestrel. And this is an important place to start with because it gives us a lot of insight into the mechanisms of action. When you look at UPA versus levonorgestrel in the upper figure on the left, you can see that the chances for pregnancy increase greatly only after about 3 days. You have a greater reduction in risk of pregnancy compared to levonorgestrel. And levonorgestrel essentially is inactive after levonorgestrel does not work after those longer time intervals. So when studies evaluated and compared levonorgestrel versus UPA, the risk of pregnancy is almost 50% lower among users of UPA compared to levonorgestrel within the first 72 hours after unprotected intercourse. Next slide. Of great importance is recent data suggesting that levonorgestrel emergency contraception also reduces its evidence for effectiveness among women of higher weight. So these data demonstrate that the expected pregnancies are no different from observed pregnancies among women who weigh more than 75 kilograms taking levonorgestrel emergency contraception in the appropriate strategy. So that's a very, very important distinguisher. So UPA not only works longer in the interval, but also works better for women of all weights, and in particular, levonorgestrel may not be effective for women weighing more than 75 kilograms. Next slide. So we know that the clinical science supports that UPA works better than levonorgestrel, and we have good pharmacodynamic data to support this as well. Studies that were done by Vivian Brachet, where they followed women with daily ultrasounds and hormone measurements until a follicle size of 18 millimeters was reached, and then dosed with either levonorgestrel, ulipristal acetate, or levonorgestrel plus the selective COX-2 inhibitor meloxicam, found that the proportion of women without follicle rupture was highest among the group that received UPA, with 20 out of 34 women blocking ovulation in this group compared to only 7 out of 48 treated with LNG, which was only slightly greater than that observed among women who received placebo of 2 out of 50. Now, the table at the bottom of the slide is important because it highlights the principal difference that if you administer the levonorgestrel before the LH surge at a follicle of 18 millimeters, only 3 out of 12 women did not show evidence of ovulation. In the ulipristal acetate group, all 8 women treated before the LH surge did not experience follicle rupture. Now, among women who had initiation of the LH surge, but prior to the LH peak, the UPA group retained activity with almost 80% of the observations not resulting in ovulation at this group. But once the LH peak has arrived, neither method has any activity. So levonorgestrel must be administered before the LH surge has initiated, and typically with a follicle that has not reached the sort of periovulatory state. Levonorgestrel works by blocking ovulation, but UPA can work and retains activity after the LH surge has initiated, but before its peak. Next slide. How emergency contraception works is related to complex feedback at the level of the hypothalamus that is the regulator of the GnRH surge. As I just mentioned, levonorgestrel must be present in circulating levels at a high enough concentration to block the initiation of the LH surge. This is actually the same mechanism involved in regular contraception, where an ovulation inhibitory level of progestogen must be present in the hypothalamic centers prior to the estrogen-related feedback initiating the LH surge. Now, the reason that the dose of levonorgestrel HC is much higher than the dose needed for regular contraception is we're trying to get to that high serum level, that ovulation inhibitory level, as rapidly as possible. This is also the reason why levonorgestrel is likely less effective in obese women, because the time taken to get to the point of reaching the ovulation inhibitory dose is delayed in obese women. And this is, again, a critical and important point to consider. In contrast, ulipristal acetate acts like a progestin at the hypothalamic centers to either block or blunt the LH surge. But acting like an anti-progestin, it works at the level of follicle to block LH-mediated events. Next slide. So what's occurring at the level of the follicle is that LH, working through its receptor, induces a number of changes that occur, which include the synthesis of progesterone, and progesterone begins to accumulate in higher levels following the initiation of the LH surge, all the way through the LH through ovulation and then into the luteal phase. Progesterone is acting to initiate a whole series of downstream signal transduction events that accumulate in follicle rupture through generation of prostaglandins, matrix metalloproteinases, and other factors. Next slide. The big question then with emergency contraception is when to restart hormonal contraception. Many women are using a hormonal method. They had a delay. They failed to start their preparation on time. And we know that the risk of pregnancy after a single act of unprotected intercourse is relatively low because most of the women simply won't be at risk. We know that in all studies of emergency contraception, the principal risk for pregnancy relates to having repeated acts of unprotected intercourse or failure to start a regular method. So the common recommendation is to continue to use condoms for at least 1 to 2 weeks or until the onset of menses, and then initiate an ongoing method of contraception. We also know, though, that among women that are given the opportunity to quick start or early start a hormonal method, the ongoing continuation rates tend to be higher. So next slide. So what we know from levonorgestrel emergency contraception is that there's no interaction. Levonorgestrel blocks ovulation or it doesn't. In the setting that ovulation is blocked, then one can immediately initiate a hormonal method without any interaction. But what about ulipristal acetate? Again, because it's functioning as a blocker of progesterone receptor, at least at the level of the follicle. Again, this study by Vivian Brachet, again, women went through a baseline cycle where they received ulipristal acetate, and then they were randomized to receive ulipristal acetate with a progestin-only mini pill containing desogestrel, or a placebo plus desogestrel. So there was a ulipristal acetate group plus placebo, a ulipristal acetate group plus desogestrel, and the placebo group plus desogestrel. What they found in dosing women that had a follicle of greater than 14 millimeters, that among those women that took UPA, you had a number of women that ovulated, but they all ovulated 5 to 6 days after dosing the UPA, which is sort of the expected outcome for emergency contraception. We want to block ovulation for at least 5 days to allow any sperm that might be in the reproductive tract to no longer be capable of fertilization. They had 5 women in this group of 29 that did not ovulate at all. Now, in contrast, among women that took placebo, followed by desogestrel, there were what I think 11 ovulations, and these occurred within about 3 days of dosing, and these then would potentially be cycles where a woman might be at risk for pregnancy because the sperm were present and they can circulate and live for about 5 days. All these 11 women would have potentially been at risk for pregnancy from that exposure. Now, what about the UPA with quick start of the progesterone mini pill? The results were in fact similar to what we see with placebo. So there's no benefit, and in fact there may be evidence of harm from quick starting a progestogen containing contraceptive immediately following UPA. And the recommendation is that we should delay initiation of a hormonal method of contraception for currently, per labeling and most practice recommendations, 5 days. And that is the recommendation that I would leave you with. Next slide. Now, there has been some additional work looking at whether we could shorten that interval, whether this applies to combined contraception. Work that was led by Alison Edelman and our group looked at a 2-day wait for initiation of a regular combined oral contraceptive following ulipristal acetate. And among women who received UPA alone, we had blockade of follicle rupture for at least 5 days in 97% of cases. But adding the addition of the combined oral contraceptive on day 2, we had an increase in the number of women that ovulated before day 5. So where it's very tempting to suggest that women are mainly at risk for pregnancy by repeated acts of unprotected intercourse, and that starting another method as soon as possible would prevent that. If that's the strategy, it makes more sense to use levonorgestrel, even though it may be less effective in blocking ovulation. It is less risky for women who have a strong desire to initiate a hormonal method early. For women who use ulipristal acetate, then we should follow the recommendation to wait, I would say 5 days. 3 days may be a conservative estimate, but 5 days is a solid estimate prior to initiating a combined method. Next slide. Again, here are these summary recommendations, and I think these are solid recommendations and reflect the best possible practice. Next slide. This is a table where I have summarized the guidance that I would suggest for initiation of a variety of emergency contraception methods. The upper portion of the slide simply compares the existing methods of emergency contraception and when they can be initiated. Just to refresh your memories, copper IUD is the most effective method because it also has a contragestive property. Copper IUDs actually work in the post-ovulation setting, where our oral EC, both UPA and levonorgestrel, must be dosed either prior to, in the case of LNG, or prior to the LH peak, in the case of UPA. In all cases of using hormonal EC, condoms are required. Using levonorgestrel, you can initiate any method immediately. Whereas if you are considering a hormonal method, it makes sense to wait, again, at least 3 days, but possibly up to 5 days before using a hormonal method. Next slide. What we know, to summary, is that UPA emergency contraception is more effective than levonorgestrel. We discussed the rationale behind this is that UPA not only blunts or blocks the LH surge, but it also will prevent follicle rupture for up to 5 days. It has downstream effects at the level of the follicle by blocking a progesterone receptor action. We know that levonorgestrel EC is affected by obesity. We don't have evidence at this point that UPA efficacy is affected by obesity. So it makes sense to consider use of UPA for the longer window of activity and its higher efficacy both for normal weight and obese women. Ongoing contraception is critical, but if you're considering quick-starting hormonal contraception, you need to take into consideration that the efficacy of ulipristal acetate will be reduced.
Thank you, Jeff. We're going to move forward a little bit and talk about that ulipristal acetate can be used not only episodically, as you described, but in continuous form. And to present that data, I have the privilege of introducing Thomas Kimball, who is an associate dean at Eastern Virginia Medical School and has had a long history in working with the ASRM and in contraceptive development, including the CONRAD program. He has been a faculty member since 2008, and his primary interests, which he'll describe to us, have been regarding uterine fibroids, endometriosis, inflammation, as well as contraception. Dr. Kimball, a pleasure to have you.
Thank you. I'm really glad to be involved in the program. My name is Thomas Kimball. I'm an associate dean and assistant professor of obstetrics and gynecology at Eastern Virginia Medical School. And I'm going to now discuss the continuous use of ulipristal acetate. My disclosures are that I have research funding from Bayer, Sabella, Medicines 360, Inovio, and Gynecologic. I'm also on the Speakers Bureau or a consultant for Bayer, Merck, AbbVie, Exceltis, Lupin Pharmaceuticals. So we've heard about the temporary use for emergency contraception. And now, as I mentioned, we're going to talk about the continuous use of ulipristal acetate. So historically, selective progesterone receptor modulators were developed in the 1980s. And some of us may remember RU 4886, which eventually became to be known as mifepristone, developed in France back in 1980. And then it was approved for pregnancy termination in 1988. So it had been shown to decrease menstrual bleeding and also decrease the size of uterine fibroids. So there was interest in possibly using it for those indications. However, one problem was that initially there was a concern that ulipristal acetate may have anti-glucocorticoid activity. Therefore, maybe it wasn't ideal for continuous use. We're not as concerned about that anti-glucocorticoid activity as we were at once, but still something to consider. Ulipristal acetate was then developed by the National Institute of Child Health and Human Development, NICHD, at Research Triangle Park. And it was also shown to decrease uterine bleeding and fibroid volume. And also remember the initial designation CDB 2914. So one of the benefits is it did not show the anti-glucocorticoid activity that we saw with mifepristone. And it was not an abortifacient. And the way that it worked was it interrupted the LH surge and it inhibited follicular rupture. But at the same time, it did not affect estrogen levels. The patients didn't become hypoestrogenic. So there was some interest in using it for more continuous indications. So PEARL studies were done in Europe to look at the use of UPA for the management of symptomatic uterine fibroids. It currently is actually approved for the treatment of fibroids in Europe, Canada, and in South Korea. So the Pearl studies were randomized controlled trials looking at either 5 milligrams or 10 milligrams of ulipristal acetate given continuously. And what they saw was that it seemed to work pretty well. There was amenorrhea in up to 90% of participants in the various Pearl studies, and they also observed ovulation inhibition in up to 80%. So the first one was the Pearl 1 study. This was a 3-month daily dosing of ulipristal acetate. They looked at, and I believe that it was randomized 1:1:1, 5 milligrams, 10 milligrams, and then there was a placebo controlled. The Pearl 2 study was also a 3-month treatment of 5 milligrams of ulipristal acetate or 10 milligrams, but they also did a comparison to leuprolide acetate. That one was also randomized 1:1:1. The Pearl 3 study was a 3-month dosing at 10 milligrams, but they added northisterone acetate or a placebo, really to look at if you were to add back northisterone acetate, how would that affect the treatment? And then the Pearl 4 study was a once daily dosing for 3 months. And they did it segmentally, so a 3-month segment followed by another 3-month and up to 4. That was at 5 milligrams and 10 milligrams of ulipristal acetate. So we were able to get a lot of information, and these are the studies that helped get it approved in the EU and Canada for the treatment of heavy menstrual bleeding related to uterine fibroids. So one thing I focused here on this slide, this is from the Pearl 1 study. This is where they looked at the ulipristal acetate versus a placebo for people who had uterine fibroids and were going to subsequently have surgery for the fibroid. And what I'm focusing in on here are the treatment emergent adverse events that were greater than 3%. And as you can see, some of the common things that we see in this class of medications: headaches, breast pain, constipation. There were also some reports of hypothyroidism from the clinical trial. Now, this is looking at some of the treatment emergent adverse events from the Pearl 2 study. And remember, this is the study comparing ulipristal acetate to leuprolide acetate, also in women who had uterine fibroids. And the adverse events that were reported greater than 3% in the study, again, there are some of the common things that we see, and just focus on what you see at the different doses of UPA at 5 milligrams and 10 milligrams, but also what you see with leuprolide acetate. So some of the more common side effects: hot flashes, headaches, abdominal pain, nausea, fatigue, anemia, nasopharyngitis, nostalgia, pharyngitis. Those are common things that we see in this class of medications. But again, focus on UPA versus Lupron. All right. Now, what I've done in this slide is I took some of the safety parameters that were collected from the Pearl 2 study as far as laboratory parameters, and focused in on some of the liver transaminases, and I highlighted those here so that you can see there was not a significant change in liver transaminases in the Pearl 2 study. This study had an N of 64 women in the study. So again, I'm going to come back to why this is important in a couple of minutes. Now, back to looking at it for continuous use. So it is being used continuously in other parts of the world, in the EU, Canada, and South Korea for the treatment of uterine leiomyoma. There's also an interest in using it continuously for contraception. So it is already used in other countries and the United States for postcoital contraception. It's taken 30 milligrams in a single dose orally, and it must be taken within 5 days after unprotected sex. And it's been shown to reliably affect and inhibit ovulation. So, of course, out of that, an interest came, well, can people use it as a continuous form of birth control? We've got lots of different options for birth control, but more are needed to increase user satisfaction. So one of the first studies that looked at using it continuously was in 2007, a prospective randomized control trial looking at using ulipristal acetate continuously and whether or not it inhibited ovulation was published. And in that study, the oral doses of 5 milligrams or 10 milligrams were investigated. Ovulation was suppressed in about 80% of the subjects, and from that we know from, I'm sorry, this is from fibroid studies. We know that it suppresses ovulation in 80% of subjects and causes amenorrhea in up to 90% of people from the fibroid studies. The NICHD also had an interest in the continuous use of ulipristal acetate for contraception. So a randomized double-blind clinical trial was put together. It was the CCN 013 study, and that study investigated the 2 doses, 5 milligrams or 10 milligrams, versus a dose of 5 milligrams in a extended cycle regimen of 24 days on medication with a 4-day medication-free window. The primary objective of the study was to look at the pharmacodynamics of the 2 doses, 5 milligrams and 10 milligrams, and compare it to also dosing 5 milligrams in the continuous, in the extended cycle regimen. Some of the secondary objectives were looking at menstrual bleeding, follicular development, endometrial safety and parameters were monitored also in the clinical trial. Some of the primary endpoints that were investigated were ovulation inhibition, and this was done over 3 28-day cycles. So the people were on medication for 3 months, and then 2 consecutive serum progesterones greater than 10 nanograms per ml was defined as ovulation, or having the development of a dominant follicle greater than 13 millimeters without a second high progesterone level was also defined as ovulation. Several secondary endpoints were also included, I have listed here, such as menstrual bleeding, endometrial parameters like safety, and the pathology of the endometrium was evaluated. Endometrial thickness by ultrasound was evaluated. We also looked at user satisfaction in the study. Now, there was also the CCN 013B side study that was done, which is also a multi-center open label clinical trial looking at UPA continuously at 10 milligrams. And the objective was also to look at the contraceptive efficacy of 10 milligrams given over 10 months. So the primary endpoint for that study was the contraceptive efficacy up to 10 months, and this was done by a calculated Pearl index. Secondary endpoints were also to look at safety, adverse events, serious adverse events. Labs were monitored, and including endometrial thickness, changes in the endometrium, and other hemostatic parameters were monitored. So not only has oral dosing been investigated as a continuous delivery system for ulipristal acetate, other delivery systems are also being investigated, including intravaginal rings. And so the Population Council actually developed a silicone ring that was made of a silicone membrane and a silicone matrix that included micronized ulipristal acetate. It was designed to be used for 3 months with the continuous delivery of ulipristal acetate. And various dosing of the rings have been investigated from lower dose up to higher dose, going from 400 to 500 microgram release rate per day, up to a 2,500 microgram release rate per day. And our speaker, Dr. Jensen, is really an expert in this area. He has published and was an investigator in the clinical trials for the silicone ulipristal acetate ring. And what's interesting, if you look at the data here, one thing that came out of the studies was that a minimum threshold of 7 nanograms per ml in the serum is what's needed to consistently affect ovulation. And you can, if you look at the table, you'll see under the 25 microgram ring that that was the ring where you really started to see more of a consistent ovulatory dysfunction and a luteinized unruptured follicle starting at the 7.19 nanograms. So what's was also demonstrated, if you look at the bar graph, is that this is a very reversible form of contraception. So in the initial control cycle, ovulation was demonstrated in all of the participants. And then by cycle 1, and this is comparing a 1,500 microgram ring and a 2,500 microgram per day ring, you can see that there was significant inhibition of ovulation over 3 months. And then in the post-treatment cycle, ovulation returned. So this is a reversible method. People's fertility returns when they discontinued the ulipristal acetate intravaginal ring. So there's a lot of interest in other indications that we could benefit from the continuous use. Again, it is used continuously in the EU and Canada and South Korea. Well, unfortunately, there were reports of people who had liver failure and increases in their liver transaminases. And initially there were 4 reports of people who with liver failure that required a liver transplant in the EU. And at that point, we were actually starting randomized clinical trials in the US to look at the continuous use for the treatment of fibroids. Those were put on hold. So were the studies, the NICHD studies that we just talked about, looking at the continuous use for contraceptive indications. So further investigation was done. It was still available in the EU until recently, and as you can see here, I've got the announcement from the EMA. While under investigation, there, to my understanding, was an additional case of somebody with a liver injury who was taking ulipristal acetate for the treatment of uterine fibroids and heavy menstrual bleeding associated with uterine fibroids, who subsequently needed a liver transplant. So this announcement came out from the EMA on March 12th of this year. And so now it is on hold also in the European Union. So it's really interesting. I do want to make sure I clarify that this is for the continuous use of ulipristal acetate that it's on hold, not for the temporary use. So it is still a very safe and highly effective form of postcoital contraception. We're going to have to wait and see what's going to happen. I showed you some data from clinical trials that at least in the studies, there weren't significant changes in liver transaminase levels. So we're kind of in a hold and wait pattern right now as far as continuous use, but hopefully we'll get some answers soon. But again, I want to thank everybody, and this was a really interesting topic, and I'm hoping that we'll have more information for you to come. Thank you.
Thank you very much to Michael Thomas, who's going to talk to us a little bit more about some of the gynecologic uses. Mike Thomas is an REI professor and chairman at the University of Cincinnati, and with long history and research in this subject. Mike, please take it away.
Hi, I'm Michael Thomas. I'm a member of the ASRM board and have been tasked to talk about Ulipristal when it comes to not only fibroids but and endometriosis, but also some of the potential side effects that have caused us to sort of take a pause on its use right now. I have only a few disclosures. One, I'm doing research projects with the EvaFilm, and I'm involved as the REI division member and REI division chair at American Board of OBGYN. Next slide. When it comes to Ulipristal, there's more data right now on Ulipristal acetate in fibroids than there is in endometriosis, but you can use it for both. Ulipristal acetate has been noted to be a treatment for fibroids, and Dr. Tommy Gimbel also mentioned the fact that it can be used in fibroids, but I'm going to go through a couple of studies where it was used successfully. In this study, Jim Liu, who's at the University of Case Western University in Cleveland, did a multi-center study a few years ago where he looked at Ulipristal 5 milligrams versus 10 milligrams versus placebo, and it was a sort of a phase 3 prospective randomized double-blind placebo-controlled crossover study. It was 12 weeks of treatment period, then another 12-week treatment period after a rest period. Next slide. So in this particular study, Dr. Liu and cohort and colleagues had a screening time frame of 10 to 12 weeks of patients who had fibroids, and then they were placed on a course of either placebo, Ulipristal 5 milligrams, Ulipristal 10 milligrams. Keep in mind that this is compared to Ella over-the-counter Ulipristal, which is 30 milligrams. So 5 milligrams daily for 12 weeks versus 10 milligrams daily for 12 weeks with patients who had fibroids versus placebo. And then they had an off treatment after 12 weeks for 2 cycles. And then they tried again. Those who were the second course were patients who had taken placebo before are now given treatment of either Ulipristal 5 or Ulipristal 10. Those who took 5 before, after the off treatment cycle, were given 5 versus placebo, and Ulipristal 10 patients were, after their off treatment, were given 10 again or placebo. And as I said, the 5 milligram people got 5 milligrams or placebo. Next slide. And the study pretty much showed that across the board, this is a very busy slide, I know, that across the board, the treatment arms were basically the same, the placebo 5 versus placebo 10 versus the 5 to 5. All these patients ended up having no real differences when it came to racial differences, age, or any of the quality of life areas that we looked at, which included concern, control, and also they looked at hot flashes and fibroid size. Next slide. When they looked at the course 1 and then off treatment interval, there were no deaths. There were very few serious adverse events, and the most frequent adverse events were low percentages of hot flashes, headaches, fatigue, and nausea. Next slide. And then from the course 2 and follow-up, this was the second course, no real significant adverse events. And the only frequently reported adverse event were headaches. Next slide. So conclusion from this study was that the 5 milligram and the 10 milligram dosing was superior to placebo when it came to the treatment of fibroids. They had an increased rate of and time to amenorrhea. So if you took Ulipristal 5 or 10 versus placebo, your time to and continuation of amenorrhea was much higher than you saw with placebo. Ulipristal in either dose caused a reduction in fibroid volume, and there was improvement of all the quality of life indicators however, Ulipristal did show a higher rate of hot flashes. There was one serious adverse event. It was a severe hemorrhage in someone who was taking the 5 milligram dose of Ulipristal during the second course of treatment. Next slide. A second study by Bressler, which was published this past year, was basically a case report, and this is for using Ulipristal in endometriosis. As I said, there's not a lot of data out there yet about endometriosis, but there is some data. Unfortunately, they're either case reports or case series, and this is the most recent one. This is a case report of a 25-year-old G0 with refractory pelvic pain and surgically diagnosed endometriosis. She'd failed OCs and failed surgical treatment in the past, and she was having menstrual cycles up to 20 days. Next slide. So it gave her half a tablet of Ella, which was 15 milligrams for 4 days, and that was given 4 days per week for about 100 days. And it's easy to do. I've used, and a patient of Dr. Lutz came to see us in Cincinnati who was on Ella, and she just bought a bunch of Ella. She was taking for her fibroids, quarter tablet of Ella a day, and she did well with her fibroids. Stopped the bleeding, stopped any issues of pain or fibroid growth and breadth of size. And then in this case, she took half a tablet, 15 milligrams for 4 days. And this patient, after failing surgery and previous medical treatment, had a reduction in her pain score, had immediate amenorrhea, and the endometrial biopsy pre-treatment was normal, and post-treatment showed a progesterone-associated endometrial changes, the PAEC, at 11 weeks. Next slide. She had no other issues, and PAEC is a benign condition that you can sometimes see in some patients who use Ella, even though some pathologists can sometimes confuse it with endometrial hyperplasia, but it's not endometrial hyperplasia. There is a specific diagnosis for PAEC. In another study using Ulipristal for endometriosis that was published this year by Singh et al., this in reproductive sciences, there's 15 women with endometriosis. They used Ulipristal for over 27 months. 73% of them used Ulipristal in a continuous fashion. 27% used it in a intermittent fashion. Next slide. And the results showed that they had a amenorrhea rate of 72% with 92% showing a pain reduction. Then these patients had surgery after this treatment phase of the use of Ulipristal. And they showed that 86% were still noted to have endometriosis despite the fact that they had amenorrhea and a pain reduction. And when they biopsied these endometriotic implants, there was evidence of PAC in the endometriotic implants, again, a benign condition. And out of this 58% who had endometriotic PAC in the pelvis, 21% of them had concurrent PAC in the endometrium. Next slide. So one of the concerns, though, with Ulipristal, and particularly continuous long-term use, is the possibility of something called DILI, or drug-induced liver injury. Drug-induced liver injury is sort of divided into two categories. It's either intrinsic or idiosyncratic. The intrinsic group are the patients who develop hepatotoxicity with potential to affect all individuals to a varying degree. And you see that with very high doses of acetaminophen. The idiosyncratic DILI, or drug-induced liver injury, is when you can have hepatotoxicity affecting only rare susceptible individuals. So it's less dose dependent and more varied in latency, presentation, and course. So this is where the Ulipristal is thought to somehow fall, is in the idiosyncratic group versus the intrinsic group. So in Europe, where they've been using ASRM, which is 5 milligrams of Ulipristal acetate, they've been using that since 2012. And they've used it primarily indication more for fibroids, and they've noted a significant reduction in bleeding, fibroid size, and fibroid volume. Next slide. So there was, they did find DILI, this drug-induced liver injury, in 5 out of 765,000 users. 5 out of 765,000 users. That would seem like a small number, but 4 out of the 5 needed a liver transplant. So because of that, even though we're talking about 5 out of 765,000, the European Medicines Agency restricted Ulipristal acetate in February of 2018. And because of this, I am one of the original group members of the NIH Clinical Contraceptive Trials Network. And we were going to do a study looking at Ulipristal acetate 5 and 10 milligrams daily for contraception. And that study was put on hold because as we were about to do our study, this restriction came out from Europe, which then triggered a restriction by the FDA. We have since just done basically an ELA study in obese women. So women who are considered obese have been given ELA to show that, to use it as an emergency contraceptive agent versus Plan B in obese women. But our study was placed on hold because of this finding in Europe. Even though it was in a small percentage of patients, there just seemed the FDA and the European Medicines Agency wanted more information about Ulipristal before it could be used in a continuous fashion in American women or women around the world. Next slide. There are other forms of selective progesterone receptor modulators that are being developed. One is ASRM, for endometriosis and fibroids, and another one called Ulipristal CDB 4124, which means Contraceptive Development Branch 4124, and that's being looked at for endometriosis, uterine fibroids, and possible chemopreventive effects. And with that, I personally think that Ulipristal acetate will probably be used more routinely. It has a very positive effect on fibroids. There is the potential for positive effects by the few cases and the case studies and the case series that have been out there for endometriosis, but we still have to have a better handle on the effect on the liver and how it affects the liver. Thank you.
Thank you, panelists. That was a very comprehensive review. I'm going to ask Dr. Jensen, hearing this, this really is the Swiss Army knife of gynecologic uses. How is it mechanistically that Ulipristal acetate can function both as a contraceptive and as a treatment for fibroids and endometriosis?
So the answer, Kurt, of course, is the fact that these are really designer molecules, and there's a complex interaction with the steroid hormones and steroid hormone receptors, and the unique configuration of UPA allows it to have specific binding to PR in different sort of tissue-specific functions. Typically it will act in most peripheral sites really like a progestogen, and that's really is a pure progesterone receptor antagonist, and that's the majority of its action, and how it works so elegantly to manage endometriosis and fibroids, as Dr. Thomas and Dr. Kimball were discussing. Contraceptively, it's really a different effect that is more centrally mediated, and this is a sort of biochemistry that's beyond my particular understanding. But the fact is that it's this more central effect that is interfering with the activity of the hypothalamic pituitary ovarian axis that gives us this unique effect in blocking ovulation.
Yeah, one of the things that people are more concerned about is that the PAEC, and it doesn't appear to have any potential long-term effect, even though, like you said, you can use this product in a number of different venues in a positive fashion from a reproductive standpoint. Once I think people feel more comfortable with what PAEC is and what it does, I mean, I can foresee something like this being used in a ring format or even an IUD format. I think it has a lot of possibilities. I think it's, I think the Swiss Army knife analogy is probably the best one. It has a lot of potential uses, but I think that this is sort of the second generation. As we get more generations of this type of product, I think we're going to see even more use with very few, if any, side effects.
Mike, can you spell out what PEAC stands for the audience, please?
I knew you were going to ask me that. It's you know what?
Progesterone receptor modulator associated endometrial changes.
Right.
So these PAEC are changes that are noted in the endometrium, and they're just kind of funny looking cells. They are not dysplastic. It's not hyperplasia, but it confuses pathologists. And we all know that if you get 3 pathologists in a room, you'll get 3 different opinions. And this is challenging. So, I agree with Mike that these are generally not considered at this point to be of concern. But since they are also oftentimes seen among women that are at risk for other gynecologic disorders like endometrial hyperplasia or cancer, this is a big deal, and this is something that needs to be followed, and that's why there are very strict guidelines regarding the continuation and timing of ongoing therapy. I think we were through almost all of that until this unfortunate event occurred with the potential liver toxicity, which has really kind of upset the apple cart.
Yeah, I wanted to go back to that. That's what I was doing. I was trying to separate the progesterol changes, which has got to do with endometrial changes, from the safety profile, which we've now seen in the liver. One of the audience members suggested that, are we saying that these changes were associated with Tylenol, which also can cause liver damage, or are the numbers so small that we just don't know the difference? But again, we're talking about now a different safety profile. And when we started moving to large scale use in women, we found that there's potentially liver damage in these small numbers. And Thomas, maybe you want to just mention, do we know what this is, or will the hold ever be lifted, or where do we stand?
I think as people, Thomas, I'm sorry.
Either one.
Go ahead. Why don't you go ahead, Tom, Dr. Kimball?
Well, yes, thank you. So one thing is if you look at the EMA announcement, as Dr. Barnhart alluded to, this is a very small sample, and the EMA announcement said, I think, whatever the number of people who in the EU were using Esmia, it's in the order of hundreds of thousands, and then you had first 4 cases and 5 with liver failure to the point that it required a liver transplant. And I don't know about the other speakers. I'm not familiar of any cases in North America. It's uses Fibrostol in Canada. I'm not aware of any, and so we're looking at two different populations that may have other risk factors, other exposures. So I don't know. I'm hoping that this will be temporary. I think it works great, and it is the potential for other uses that we've discussed is out there. But honestly, we don't know.
So
it'll be interesting. It'll be interesting to see if you see that with the other developing generations of the progesterone, the selective progesterone receptor modulators. You know, the initial one, the first generation, which was the mifepristone, showed the glucocorticoid effect, the anti-glucocorticoid effect, and then now you have the increase in PAEC, which appears to be really probably nothing, but it just gets misread by pathologists, and it could, you know, throw people off a little bit about its use. But now with the liver issue, we just need to get more data on it to see and look directly at those 5 patients out of 765,000 patients to see if they were at risk. We saw this with triglyceridone a number of years ago as well.
So let's go back to the positive of this. So we only have a couple of minutes left. This agent serving as a selective progesterone agonist can have wonderful aspects of amenorrhea for both endometriosis and fibroids. One of the questions that was asked to me is, how does this amenorrhea or bleeding profile compare to progestin only, say norethindrone 5 milligrams? Is it better, the same, worse?
I would think compared to, it seems to be much better if you look at the data that I presented. Norethindrone acetate, the 5 milligrams, you generally get some irregular bleeding, even the longer they stay on it, because you get this atrophying of the lining of the uterus. And with the Ulipristal acetate, it appears in the patient populations that have been studied, you don't really get bleeding at all.
Yeah, my impression was that the bleeding profile is far better and much more amenorrhea, that this isn't just another Me Too drug. This has the real potential of being a game changer for women with fibroids and endometriosis, assuming we can pass the safety profile and such. I think we're getting close to the time, but I want to go around the table, if we will, and why don't we start with Dr. Jensen and give some final thoughts on where you think Ulipristal is, what do you think its most beneficial aspects are, or whatever you want to say.
Yeah. Well, you know, I agree that the liver issue is confusing. And I think it's important, though, to recognize that when you dose anything orally, you know, it's going to the liver, and idiosyncratic liver reaction is not something that our colleagues that are in gastroenterology are not used to seeing. There's a lot of things that will cause liver toxicity. This may be present, it may be real, but the problem is that it's a very small population. I think that the use for emergency contraception is extremely important to recognize that that's not a consideration with single dose or even repeated single dose. So I don't believe that that's going to be an issue that will remove anything from the market. Dr. Kimball talked a lot about the vaginal ring UPA. That is a non-oral route of administration. I believe that's one that also would be potentially very, very useful moving forward, and I would love to see additional work move in that direction.
Yeah, you know, it'd be interesting to see if you see the same changes in a continuous use versus an intermittent use format for any of the, either as a contraceptive agent, a treatment for fibroids, or for endometriosis. And also to even look more deeply into the patients who did have a significant liver failure that required transplant, did they have any other predisposing factors? So I think the jury is still out on exactly what happened, but I think it's something we need to look at with caution.
Dr. Kimball?
Thank you. So as far as it's used as an emergency contraceptive, as Dr. Jensen said, I really hope that there is not a mixed message that the medication is not safe. It is extremely safe and very effective, much more effective than levonorgestrel as a postcoital contraceptive, emergency contraceptive. My biggest concern about UPA, I was in a study and on a paper a few years ago, is pharmacists don't know about it, and neither do a lot of providers. And so with its efficacy and lack of efficacy of levonorgestrel, especially in women with higher BMIs, I'm hoping that people will start offering it to their patients more. As far as continuous use for contraception, again, we need more options for patients. We still got great options, but there's more work. And I'm really glad that the POP Council and Dr. Jensen and everybody who's been involved at looking at other delivery methods where you can avoid first pass metabolism, like the vaginal ring we discussed. It was also mentioned intrauterine delivery of UPA. And then there's tremendous interest in other indications, fibroids, endometriosis, a few other indications, people, infertility for Ulipristal. So I'm really interested in seeing what happens in the EU and the EMA's decision, FDA's decision here. One thing I did present was some of the data from the studies. It wasn't great, but there were no changes in the U.S. study on liver parameters.
So I'll end it with that. We've all been practicing gynecologists for a long time, and the treatment for abnormal bleeding or for fibroids or endometriosis or even emergency contraception hasn't changed in decades. And Ulipristal is a success story in our lifetime that we've seen people like Diana Blythe and others at NACHD push this forward and get very rigorous research. I feel we're caught up in that research, in that we have really, really good data, but no data is perfect, and there is some safety issues that we have to look at. I'm personally not all that concerned with the endometrial associated changes, as we went through that unexpected change, but now we're stuck with these liver changes, and we need to find out if they're real, acceptable, or can be altered by add back or intermittent dosing. But I do think Ulipristal acetate is the Swiss Army knife of gynecologic use. I thank my panelist who reviewed its use in emergency contraception, potentially as a continuous contraception, and potentially as gynecologic uses for endometriosis and fibroids as well. Thank you for the participants on the web. I hope I got most of your questions, and I look forward to speaking to you on a future ASRM webinar in the future. I think we're going to hear some brief announcements to say how you can further get questions by email or other reasons, and we look forward to answering them as well.
Thank you, Dr. Barnhart. Thank you for moderating the Q&A. Thank you to our panelists for sharing your recommendations and valuable data on the Swiss Army knife, and to the attendees, thank you for joining us. You will receive a survey by email after this session. Your feedback helps us give you the most relevant content, and your input is appreciated. This session was recorded, will be available on our website in the near future. Please join us for our upcoming webinars. Watch your email for notification. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar. Thank you.